mode.
Oh, well, hello, and a very warm welcome on what certainly in London is a very warm evening. So this is the latest in a series of Densura webinars, and really looking forward to this one, which is a guide to success. I'm particularly excited because with me this evening I've got Dr. Julian Perry, and it's fair to say that Julian's had his fair share of success over the years, both in private practice as an implant surgeon, but also in helping to build a business that was Oasis and is now part of Bupa, and then subsequently being a board member of My Dentist. So I've known Julian for nearly 10 years now, and amongst his many achievements, the one that I'm most pleased about is that he worked very closely with me in developing the Densura product. He was instrumental really in putting that together, and for that I'm very, very grateful. So good evening, Julian. I do hope that this will be, I say, a very entertaining 40 minutes. We're looking forward to it. There'll be some questions, I'm sure. So if there are questions, please just submit those on the box on the screen. I'll keep a record of those, and I'll try and deal with those at the end. I think we're going to try and run for about 40 minutes. So I think without further ado, over to you, Julian.
Well, Kevin, thanks very much. For those of the more observant of you, if my nose is red today, I've been sailing today. I just thought I'd share that with you. Not that if you've been in surgery, that was terribly helpful, but there you go. Yeah, welcome. I'm just going to share my screen. Kevin, can you tell me, has that come up? Can you see my screen? Good. Okay. So there are a number of topics, with the exception of the first one, what dentistry looks like post-2021, i.e. what it looks like now. Each of these other topics, good dentist, what makes a good dentist and a great dentist, start with the end. Each of these are probably in their own right 2 days. So what we're going to do is we're going to romp through at high level, and we'll take questions at the end. You know, some of you might get a little frustrated if it's a bit shallow, but as I say, if we get through sort of 40 minutes or so and you have questions, I'll happily answer them. So what does Dentistry look like now, you know, post 2020? Well, we're in a situation NHS-wide where, you know, we're delivering 60% and getting paid for 100%, and that's marvelous. I think it's also hard. What we've seen, however, is an artificial spike in private sales. And a lot of people are hanging their hat on the fact that their private has grown massively, and I think that's great. The downside, of course, is that once full capacity is required by the NHS, that artificial hiatus, that artificial high, will be forced to come down simply based on the number of hours that you have available in the surgery. There's a couple of watch outs coming. So some of you will know this, and I apologize if it seems like I'm teaching you to suck eggs, but 10% of dental nurses have not re-registered with the GDC this year. That's 5,200 nurses. And that's the most significant nurse drop-off since 1947, I think it is. And you know, there'll be a myriad of reasons, but the reality is what that's done is that's led to creeping wage inflation, and nurse wage inflation is increasing. It's running at about 23% so far, but there are some parts of the country in hard to fill areas where nurse wage costs since coming back and working are up as much as 70%. The other point I'd like to make is that 23% of our dental workforce is no longer able to come into the UK. There's 23% of all dentists are trained in non-UK establishments, and with Brexit, that's been nicely switched off. 7% of older dentists, I'm in that bracket, but any dentist over the age of 55, it's estimated that 7% have gone 3 to 5 years earlier than they might have. The last little statistic which is interesting is Brexit has added between 14 and 17% to the cost of materials, because we don't manufacture much in the UK, it's all European, so thank you again, Brexit. And the other thing just to mention is we're going to see substantial pressure on laboratories because, of course, the precious metal supply, the porcelain supplies, labour costs, etc., will all go up. And a number of labs I've spoken to, and I speak to a good number of laboratories, are having to put their price up somewhere between 10, 15, and sometimes 20%. And that doesn't really surprise me because material costs have gone up. And also the lab industry I've got huge sympathy for, because in the times that the rest of us were getting some money from government over COVID, they got nothing. So that's where we are. It's an interesting, so if you're an associate, it looks good temporarily or provisionally, but it's not in the long term good. Because as an associate, if you're in a stable practice, you need to be conscious of the pressures that the principal in the practice will be experiencing. Nurses costing more, materials costing more, labs costing more, the cost of running a practice more, the hassles that you have associated with limited access and PPE. So my recommendation for associates and principals alike is get together and work out how to be better together. And the only way that you can actually combat these changes is by increasing the amount of private. You can't run any faster in the NHS hamster wheel. It just isn't possible. And the faster you go, you will still have the incremental costs. So my view, it's my view alone, well, it's not my view alone, I share with a lot of people, but you need to increase the amount of incremental private that is done by associates, by principals. Okay, so that's the brief overview, that's the summary of what it is. I mean, there's a lot more to go into that, but we don't have time to go into sort of the subsets of all of that. I'd like to touch on what makes a good dentist and what makes a great dentist. Now, everything I show you on this presentation, I've done. Okay, so there isn't a single figure in here which is not based on in fact. And also I have a pretty extensive number of dental clients over the last 30 odd years who will bear testimony to the fact that what I'm telling you works, you just have to believe it. Then we're going to move on to start with the end in mind. The reason I put that in is so many colleagues that I come across don't actually have any kind of plan. You know, they go to work, they work as hard as they possibly can. They come out, they go home, they have dinner with the family, they go to the pub, they come back, they work as hard as they possibly can. But there isn't any structure, and that's, again, nobody's fault. Nobody in dental school teaches you to have any sort of business mind. You know, they teach you to be, very good mouth carpenters and very good dentists. But that is only one element of running a successful business. We're then going to move on to niche markets, and actually, it's a fairly strange term I've used, because none of them are niche, they're all mainstream, but I've sub-categorized them into 5 to break them down for ease of explanation. Then we talk about, protecting yourself with proper indemnity. Why did I get involved in that? When I was working in Oasis, and I was the clinical director, I got completely fed up of how the associate dentists were being treated by a number of the defence organisations. Complaints were coming in, they weren't being handled quickly enough. And the problem was, if you didn't tackle these problems early, the delays and the photocopied letter saying we're looking into your case simply wound the patient up. So you took something that was really simple and you turned it into a monstrous problem. And at the end of this, if you want some really stupid examples of how to get it wrong, please pop that in a question and I can give you some amusing anecdotes which are absolutely true, which led me to getting in touch with Kevin and deciding that as a dentist advising him, we could do a lot better, we could get a lot better cover in there, and we could do it less expensively. And then the very end, subject to time, is how do you talk to your patients to avoid the problems? So let's just skip through this. So what makes a good dentist and what makes a great dentist? Okay, so clinical skills are in there, but that's not the key, because we have to assume that as dentists, you're able to wield a slow handpiece and a fast handpiece and work well with mirror probe tweezers. What makes a good dentist is, how you present, the confidence. You need core knowledge. You've got to work with a great team. Your environment needs to be good. You can't be in one of the old-fashioned sort of, greasy spoons and compete with, a posh restaurant. The whole thing, equally, you don't need to be, all glass and chrome and fancy. There is a middle ground, but, the environment leads to confidence, which helps presentation. You have to have a team that works. If your receptionist is sat with her feet on the if you sat with the feet on the desk, you know, smoking a cigarette and eating a pork pie, that's not going to give you it's not going to present you in the right light. The two key bits I want to talk about here is the 2 points that are highlighted here. One is restore and not repair, and the other is menu-driven clarity. And then what takes you from being a good dentist to a great dentist is all of the above, but then, and I use the word very carefully, specialization in communication skills, co-diagnosis, use of animations in discussion, reinforcement. So in this, what you learn to do is you learn to take the patient, the client, on a journey where you co-diagnose. So you are reinforcing the suggestions and the interest that the patient shows. There's a little bit of NLP, neuro-linguistic programming. That's actually just simply a way in which you can build a rapport, but it's often, all my nurses were trained in NLP. And again, I'll touch on NLP at the end in question time if we have. You follow up. Hang on, I've got a message. Okay. You follow up, and again, what we see in dentistry is people do stuff to patients, and then the patient goes through, and the sausage factory comes out again. You see the next patient, you know, and that again is not good. You need to seek out perfection. You need to challenge your work. You need to recognize the patient as a client and the importance for your business. So it's not treat and forget. And again, question time, we can go through some of this. So what is private, right? It's presentation, it's look and feel, it's co-diagnosis. This one is so important. This one, communication, is so important. With these two, as you get good at these, confidence comes. And there's no I in team. I know it's tried to say, but if you don't have a team, if you tick off your receptionist, your receptionist is your gatekeeper. And if you annoy the receptionist, you upset the receptionist, you're disrespectful to the receptionist, you'll find your flow of patients dries up. In the same vein, remember the nurses that work with you are your right arm. I have Beth, she's my implant nurse. Frankly, if Beth wants more about it, to go on holiday, I Dentistry on holiday because she knows about implant than almost any dentist I've come across. And I don't want someone else to take the place. So the team is really important. And then this one, not to be underestimated. When I say slick paperwork, I'm not going down the American route. I'm simply talking about paperwork which is efficient, respectful of the individual's time, and then after all that, you pick up the tools. It's really is honestly that simple. So let's come on to niche markets. So the niche markets are restore or repair, menu-driven pricing, aligners, implants, cosmetic bonding. So like I said at the beginning, none of this is anything that any of you don't know anything about. Sometimes it's how you look at it. So let's just wander through. But before we do that, I touched on the fact you need to understand how much you need to earn. So if you're a principal in a business, you need to do your business flow cash flows. You need, as an associate working for a principal, you need to understand how much you need to earn. You need to understand or the wife or the partner or the kids or the school fees or the boat or the car or the holidays, right? Instead of just sticking your thumb in the air and giving it a go, actually sit down and make a plan. Because once you've made a plan, you can then calculate how much work you need to do, not how much work you want to do. And if the work you want to do in hours, days, and months doesn't give you the income required, you're going to have to tailor your desires. I hope that makes sense. Because you need to work out your income requirement, and that's inextricably linked to the hourly rate required and the number of days you want to work. And work it all out, and then don't do what most people do, is forget about tax. So let's crack on with niches. So I'd ask you a rhetorical question because you can't actually answer the question at the moment. But let me ask a question I always ask. Why do we do fillings? Right, and the usual answer, I usually get a blank look from people who say, well, we do fillings because we're dentists. We don't do fillings because we're dentists. We do fillings because that's what we were taught to do with dental school. And British dental schools particularly teach you to do fillings because we come into the sausage factory that is the NHS, and that's what the NHS like us to do. There are lots of European colleagues and dental schools who don't start with amalgam. Well, lots of them don't do amalgam at all, but they don't even start with composite. They start with inlays, onlays, crowns. They restore, they don't repair. So my first point is, don't always assume, in fact, I never assume that the best restoration is a filling, because it's not, because I don't have it. In my mouth, I have ceramic inlays, onlays, I have gold inlays that have been in there 25 years. And I don't have any dental needs because the stuff that I've had done lasts. Amalgam is a good material. Composite is a less good material. It just happens to look a bit prettier and a bit white, but in terms of material science, it's not as good as amalgam in most situations. But then, of course, it doesn't contain amalgam. It doesn't contain mercury. But of course, if you look into the material science of composite, there are plenty of carcinogens in composite. So I wouldn't get too hung up on the argument, I'm doing you a white filling because we don't want to give you mercury poisoning. Because if anyone looks too carefully into composites, you'll find that's not a clever response. A consultation is not about counting teeth or charting decay. It's not about band 1, 2, or 3. It's about taking a view of the patient, having a look, talking to the patient, and co-diagnosing. How do you co-diagnose? Well, first of all, you pre-screen. You have to ask the right questions, either when they filled in a form saying things like, if you could afford it, would you like to have your teeth lightened? If you have missing teeth, would you like, or if you have to lose a tooth, would you like that tooth to be replaced? You don't be more specific than that, but you build up a platform, you build up a plan, an outline of what that patient is thinking. Now, a lot of the stuff that we've done recently is online virtual consultations with new patients to talk about their desires. That actually works fabulously well because it's a non-stressy environment for the patient. So you can have an open chat, you can have a relationship building exercise, you can talk like human beings. They are usually less anxious, and it opens up all sorts of opportunities. Coming back to the clinic, always take photos. I don't understand these days when everyone doesn't have a scanner. A scanner, just to be clear, a scanner is not an impression taking machine. Right? If you ever get sold on a scanner because it takes impressions, it's not good. It's not cheaper, it's not more cost effective, you don't save on the materials. So you need to understand what the benefits of using a scanner are, and I'll talk about that a bit later. But don't buy a scanner because it takes nice impressions, because I'm sure a lot of you can take very decent impressions with silicones and alginates and everything else and not have to invest in the 20, 30, 40 grand in a scanner. A scanner, however, is the best tool you can get in the modern digital world, because impressions are analog, digital scans are the future. What you do is you take all this information, you share it with the patient. Like I said, this is a 2-day course. You share it with the patient, you co-diagnose, you ask the right questions. So, for example, I did an exercise with a clinic in Kingston and Kingston is like the Chelsea Tractor Brigade, Kingston and Thames, just outside London. And I went to a clinic because the 4 dentists there said, you don't understand, none of our patients want tooth whitening. And I was glib. I said, well, so they come in and ask for dark teeth. And they scoffed at that. And I said, well, you're not asking the right questions. So we put in a questionnaire, and the question was simply, if you could afford it, would you be interested in lightening your teeth? Patient wants to say yes. And what you do is you use reframing and reinforcement. So when you go through it, you pick out your Vita Shade Guide, you stick it across, you say to your nurse, the canines are A3, centrals are A2. Do you know what, Mrs. Smith? Actually, I think you made a good decision there. We could just lighten those a little bit. You're not trying to turn them into a Hollywood film star, but reinforcing the patient's own decision makes it very difficult for the patient to change their mind. So it's a subtle form of selling, and it's or communication, and it's an ethical way of doing it because you're reinforcing what they have done, or what they have intimated they might like if it's fully explained to them. And then finally, and I'm going at 100 miles an hour, so I apologise for the pace, but finally, offer restoration as well as repair. And if a filling is chosen, which is fine, because you're offering a suite of options, people must be allowed to choose. Warrant it as a repair, not as a restoration. You say, fine, I'm really happy to do this composite filling, but understand it has a warranty of 12 months. Whereas the inlay, onlay, crown, etc. that I could do over here, yes, it's 3-4 times the price, but it has a 5-year warranty, an 8-year warranty. And people say to me, oh, I don't want to warrant my crown and bridge more than a year, in which case, either you're not a very good dentist or you're putting it in a mouth that's filthy and you need to sort out the perio and the oral hygiene first. All my life, I've warranted crown and bridge and what I call proper restoration between 5 and 8 years. And I still live to tell the tale. And because I've priced it correctly, on the odd occasion one goes peak-tong, and the patient comes in starting to be a bit agitated, saying, you did this crown 3 years ago and it's broken. I say, Mr. Smith, don't worry, it's absolutely fine. I'll just get you another one. Well, how much is that? Well, it's nothing. Of course it's nothing. Bang, you turn a terrorist into an apostle. And how can I do that? Because I digitally scan. So I just press a button, say to the lab, that one broke, mesial cusp fell off, have a look at the design and print me another one. It's much better than litigation. It's much better than a RAF. I took my dog to the vet, and you can see this was 19th of August. And my dog, and I love my dog, I've got 2 dogs, had a very small sebaceous, 2 small sebaceous cysts on their back. Have you seen the size of the bill? You can tell I love my dog. But what this does is this brings out menu-driven pricing, and I've used this pretty much all my dental career. Because what we do as dentists is we suffer from mental fiscal drag. We think of a price, we don't really know how we actually ever got to the price. But we just go, dentures this, or filling is that. And you actually think about it. And in here, I'm amazed to find that 2A sutures are 26 quid, because I'm pretty sure they're not. But did I pay it? Yes, I paid it. My dog was happy. So think about what you do. Menu-driven pricing, you can all read: local anesthetic, disposable, 3 diamond burrs, 1 stainless steel, cavity preparation, baselining, bond, composite, disposable. Because when you drive through a menu-driven process, it's very difficult to argue, right? People go, oh, £186 for a large filling. Well, no, actually, it's a combination. Which would you like me not to do? I can not do the shim stock, but I can't guarantee you won't hit the tooth first. I can not do articulation, same thing. I can leave it rough. I can not finish it so it'll stain. I can not put, would you like me not to put the 74 pence wedge in so that you get food trap when you eat? I'm slightly glib and flip because it's nearly so. It's gone 7 o'clock at night and we should all be having a glass of wine and a trip to the pub these days. But I'm trying to make the point that it's presentation, which is essentially important. So let's come on to other niches, and again we'll go with pace. Aligners, if you don't do them because a huge amount of the population are interested in them. Just bear in mind that only about 30, and if you're lucky, 35% of people who walk through your door will be suitable for your level of aligner. 78% of the adult population over the age of 21 or 23 have some degree of lower in size of crowning, but when you look at it, only about 30% is GDP suitable. Now, if you specialize in, not that there's any such thing as a speciality, just in case you get picked up on that, but if you take a keen interest in it and work at it and you start to do a bit of IPR and a bit of other stuff, then you might add another 15%. The rule of thumb is case select correctly. Why is it a good course of treatment? Because it's non-invasive in most cases, unless you do a little bit of IPR, and if the IPR is done carefully, it's low risk. And like I said, about 35% routine. And let's come to lab fees, because as dentists, we all do the wrong thing. We all want to charge as much as we possibly can for our work and then screw our labs down into the ground for as cheap as possible. Don't do that, particularly in the digital world. Everything I talk to you about now should have lab fees of between 20 and 25%. So don't try and screw the laboratory down for the cheapest price. Find out from your lab what good looks like, because you want to be a good or a great dentist. So find out what that route is. Find out that doing it properly, using a digital workflow, using pre-diagnostic, etc., costs more. Don't cut corners. If you're doing implants, don't not take study models. Don't not plan the case. Don't go to the pub the night before and then throw some rusty nails in someone's face and hope the technician can fix the work. All that is rubbish dentistry. So start with the end in mind and plan the case. And it doesn't matter what your lab fee is if you've done your case planning. And then an aligner, it's basically make sure you allow for a bit of cosmetic bonding or take a good look at the front teeth and decide at the end, because you want the wow factor. When you finish, you want a bit of lightening, factor that in. Some of the incisal edges chipped or rough, factor it in. So that when they go out, it's a wow. And when it's a wow, go to people like Doctify, I think it is, where you can get this online, this pad in your surgery, and they can click on that and they can give you the equivalent of great Google reviews, and all of a sudden you're starting to build a portfolio of people that say, go to this dentist because he or she is amazing. Implants. Now this is my world, and I've done a lot. It's not as profitable as some people can think. A lot can go wrong. It is invasive, so it carries the risk of irreversible damage. It's unwise these days to place without holding some sort of postgraduate qualification, and restoration is complex, no ligament. I get so ticked off when I hear about people saying, oh, well, if you send your implant to me, you can put the crown on the top. Putting the crown on the top is the tricky bit. Restoring is the tricky bit. I can train a pet monkey to put an implant in, provided there's enough bone and they know how to bone graft. That's not the skill. The skill is actually doing the pre-planning, start with the end in mind, so that the restoration meets the patient's wish. So all this nonsense about treating it like it's a fence post in the garden, I've seen so many catastrophic failures on that basis. I know that's a very arrogant statement, so take it with a pinch of salt, but it's based on 29 years of exclusivity in that field. Implants require a significant commitment to personal learning. You don't go on a one-day course, and you've got to have CapEx. Basic CapEx is 15 grand. It's not less than 15 grand. You can't do a case if you haven't got your sinus lift kit and your nerve lateralization stiff, and if you haven't done your connective tissue grafting course, etc. So postgraduate training these days with a decent university is going to cost you 30. So you're up to 45 grand, and you cannot do, I don't care what you say, you cannot do implants these days without cone beam CT. Not because you don't have the skill, but because these days, medically, if you were judged by a group of your peers and you've got the dental law partnership screaming at you, and you can't demonstrate 3D planning and 3D surgery, you will fail. In the courts, you will fail. There are loads of rewards for the doing it right. I've got loads of friends and colleagues. I did really well out of it. And I'm here now, and I've virtually stopped practicing, and I've not been sued, and I sleep well at night. Labs and implant component fees should be around 25% of the case. Do not cut corners. Do not pre-plan. Do not take study models. Do not get the oral hygiene sorted. Do not do the restoration work beforehand. Implants are the last phase in a partially dentate patient. When everything else is sorted and done, it's the finishing off. Now, you can put the implant in halfway through, but you mustn't restore before the rest of it. And everyone who starts out early thinks, oh, well, there's a space over there, I can earn 2.5 grand. Don't fall into that category, because you will fail. Sort out the patient properly and get the occlusion stable, get the hygiene stable, get the motivation stable, and then do the implant restoration at the end. Then we move on to cosmetic or composite bonding. Now, the second line will have some of you irate, but I say it with confidence. Most dentists do not know how to do cosmetic composite bonding. You have people like Ivor Clark, who are world-class in this, the Liechtenstein Institute. There's lots of online training. Whereas Cults also have great online training. But this is something that you need to learn how to do. You need to learn how to make palatal indexes. You need how to do the class 4 lengthening of the teeth. You need to understand smile design. This is not banging some etch on the front of the tooth and whacking some B1 on the top. That's not composite bonding. Invariably, if you do composite bonding right, you get amazing results. I know lots of dentists who are way better than me at this, and their work is just beautiful. But you've got to know how to finish, and finishing is critical. And then don't overpromise. Always under-promise and over-deliver, because cosmetic bond will chip, will stain, and need attention. But you do it really well at the beginning, and you have very little. And offer it as part of a number of treatments. So composite bonding is one thing, but you've got veneers, you've got all sorts of other options you can offer the patient to turn them into Made in Chelsea or Towie or anyone else that decides to perma-tan themselves orange. They're slightly different again, but the reality is you can make people look beautiful if they've got minimal crowding and minimal problems using composite bonding, but it is absolutely an art form. It is not what you learned at dental school. Perio, well, I always say this, you don't need me to tell you about perio, but most dentists do. It's already sitting in your practice, and it's pretty much ignored by lots of clinicians. So, you get to a stage where when you've got a build-up of tartar, you're bleeding or probing, you've got dental disease, so you need to deal with it. There is no such thing as a single visit S&P. That serves no purpose whatsoever. It doesn't help the patient. It might make your bank balance for that half an hour a bit better, but it's not correct treatment. You can't eradicate that level of gingival inflammation and disease with a one-visit scale and polish. Now, I ran programs. I had 3 hygienists that worked with me, and we ran educational programs. And a basic course would go from £400 straight to a 3-monthly program. You'll all have had patients that say, "Well, I don't have a problem. My gums have always bled." Well, then ask them, if their hands have always bled, and the answer is not. So they've always had gum disease. So it's not a problem. But where we go wrong with this is we just get them in and we do the mechanics. That isn't periodontal program either. You need to set goals and outcomes, diet, instruction, equipment. All my patients would get an air flosser from Philips. All my patients would get an electric toothbrush. All my patients would have 2 hours with me and 4 hours with the hygienist, and they pay £1,200 for the privilege, but they would get the whole pack. Every time they come back for their 3 or 6 month review, they get another set of heads for their handpiece, and we have recorded everything carefully, take new photographs. You bring them on a journey, because periodontal disease is still the primary reason for tooth loss, and it is ignored because we are conditioned as dentists to bash the gnash and just do fillings and not worry about the actual overall health of the patient. I'm not saying you guys do that. What I'm saying is that's the way the NHS is structured. It's already sitting there. It's already available. I'm not going to go into this. There's a whole stuff if anyone's interested, I can send this stuff out to you. But there's a platform of doing this. It's ethical. I've reviewed it with the Association of Periodontologists. I've got lots of perio friends who just love this, and they're much better qualified than me. Surgical is out at the moment. Well, it's like the drain pipe gene. Sometimes it's in, sometimes it's out. If you look at all of the data on surgery, you shouldn't do surgery on gums until it's the treatment of absolute last resort. Root surface debridement, chemical irrigation, etc. Try not to cut. They're already losing their tissues. I'm not saying there's never a situation, but try not to do it. So let's talk about a bit of money. Financial. So aligners, if you went to the bottom end of the market in terms of laboratory provision, and you charge 2K for a simple case with a lab fee of 500, you net this. Now, again, I can send you these slides. I guess the point I'm making with aligners, I don't promote one or the other. You've got Invisalign, you've got ClearCorrect by Straumann, you've got Dentsply, I've got some, you've got lots of labs that do their own. The technology is out there, the software is out there. That's not really the point. The point is, with aligners, is it can go wrong and it's not your fault if you can't plan the case correctly, because the main reason for aligners not going right when they've been planned correctly is because the patient doesn't wear the aligners in the sequence as they've been told for 20 or 21 hours a day. Best advice I can give you if you're into aligners is study it, get a mentor, get someone to help you, and then use dental monitoring. Dental monitoring is a piece of software, many of you will be aware of it, and it runs on a 271-point algorithm. So the scan that you've taken, and you've got to do scans for this, the patient gets a little box, they put the camera in, the camera takes a series of shots, it uploads it, it overlays it onto the scan, and it tells the patient whether they can go on to the next aligner or not. So it just takes out the problems of they didn't wear aligner 3, so aligner 6 doesn't now work. Again, I'll answer any questions on that. Implants. The average in the UK, last time I checked, is about £2.5 per case, less costs. I can go through costs, but never cut corners. Time per case. Now, this is a single tooth implant. I put 4 hours. The last single tooth implant I took start to finish, I think the placement took me 14 minutes. But I have done a lot of them. But, this is over average. But even on this basis, it's a profitable exercise. But you have to make the commitment in time and equipment, and it gets easier and better the more you do, provided you don't start doing implants on there's a space, I'll cut a hole because I know where the lower left first molar fits, because you won't get it right. And you certainly won't get a 4, 5, 6 right. It'll look pretty, you might get them equidistant, but the trouble is a 4, 5, 6 in the upper left quadrant The implants are not equally spaced because the premolars are different sizes and the molars are different size. So use a lab, use a stent, use a diagnostic, and put the implant exactly where it should go. Cosmetic bonding, the average case for a simple smile, 6 to 8 teeth, is about 1800 quid. You look at your materials, 120 if you're not cutting any corners and use 3-phase polishing that someone like Ivoclar recommends. Time per case, 3 hours to do that. You can do it, some do it faster. But it's profitable, it's non-invasive, when it gets a big wow if you do the case selection. Financial periodontal, £1,200, cost is 175, and I've already articulated that we give them electric toothbrushes and all the other bits and bobs to make sure they have a great journey through it. That's self-explanatory, but it's in your practice, it's in every practice. That's just a process and a communication piece. And then upsell, repair to restore. So if you take an average non-restore case from 125 per patient to 650 because they have one piece of crown and bridge and the lab fees at 20%, and if 15 patients a day are presented to but only 3 buy, their improved profit against standard delivery is £343,000. There is almost nothing more profitable in dentistry and as ethical as restoring, not repairing. Analogy I give is, imagine you've got a beautiful house and you've got a beautiful sweeping drive and it's full of potholes, right? Do you always want to be told those potholes can only have a bit of tarmac shoved in and a roller and wait till it falls out again? Maybe, just maybe, because you've got a nice house, maybe you want somebody to come along and resurface the drive, or maybe you've got to a stage in your life where you haven't been able to afford it, but now you've got a bit of money, you actually want to restore your drive. It's a poor analogy, I know, but it's still relevant. So if you look at financial summary, basically aligners, do them right, they'll yield about £500 an hour. Implants are not far off at £460, but you've got the investment of the 45 plus a CBCT. I think a decent CBCT these days is anything between 25 and 45 grand. Cosmetic bonding is broadly the same, non-invasive, minimal, low risk, perio, about 400, non-invasive, low risk. Menu driven pricing, get the pricing right, no downside to that. Restore and repair, again, they're all about the same, but they're no more invasive than repair. So low risk, low risk, low risk, low risk, low risk, higher risk. Don't really say you shouldn't do the implants, you should just understand that. So why do you need? So why did we set up Densura? Well, so it's a bit like all jewelry is not the same. All bottles of wine are not the same. You need an indemnity organization that understands private. You need advisors, and we have 10 who are both dental and legally trained and offer all ranges of treatment themselves. So, for example, if there's a challenge over an endo, you want to speak to a dentist and a dental legal advisor who does endo. You need non-discretionary. Be sure nobody can walk away. You look at the policies of other large groups, other large indemnity organizations. They're all discretionary. You need a response in hours, not days or weeks. One of the things I came across, which hit me like a sledgehammer in Oasis, is that sometimes these things would spiral out of control because nobody faced into the patient's irritation. What we have is a head of legal and a negligence barrister from day one who backed the claim back. So examples of when dental law partnership have come fishing. When dental law partnership comes fishing and it's spurious, they get absolutely hit back day one by a very aggressive medical negligence barrister. And guess what? Most of the time they go away. You need an indemnity organization that won't settle when you're innocent just because it's cheaper. That happens quite a lot. And you need access to properly written patient advice, consent documentation. You need regular updates to the market. And you need to be relevant CBP. That's why we set up Densura. It was set up by a dentist, me and lots of other dentists, chatting to these guys to say, we don't like what's out there, this is what we want. And in most situations, it's 25 to 30% cheaper. Now I'm going to rattle through how you avoid complaints because I know we're running out of time. Just try avoiding them in the first place. What causes them? Most complaints come out of communication issues. They didn't understand what you said, the whole valid consent piece. Discourtesy, being aggressive, failing to explain, talking in dental jargon, being arrogant, not listening. immediately getting your back up and being argumentative and irritable, failing to educate and inform, giving an emotional response, you're defensive. The inability, I think what happens in dental school is somebody surgically removes our ability to say sorry. And the other classic one is the inability for any of us to say, I'm going to refer you to a colleague because I'm not the best person for this job. Now, I can tell you, I'm the worst endodontist in the world. I'm not bad at pins, but you would never want to refilling with me. And when my patients say, oh, but doc, I want you to do it. So if you want me to do it, you'll take my advice and you'll go and see Martin Johnson in Abingdon because he's way better than I am. And that's the way you do it. But why do they escalate? Because you're being, because they feel they're being disrespected. They feel they're getting an arrogant approach. They feel that they're not being listened to. Emotional responses, defensive attitude, all the things I said, and they also fail to get anywhere because quite often one of the challenges we have is that you come to look and the dentist says, oh yes, I remember telling him this and I remember warning him, whatever, and you look and there are no notes. So notes must be contemporaneous, devils in the detail. If you don't record it, it didn't happen, right? They need to be comprehensive. Avoid templates if you can, because pre-filled lead to mistakes, or they look like they're just pre-filled templates. Never, never, never amend a note that you've made at a later date. A good friend of mine did that. I believe in good faith and was suspended for 2 years. And he's a good dentist. He made a mistake. If you're going to make a correction, make a new note. Notes need to include all written records, including treatment plans and estimates, all x-rays, any sketches, any photographs and scans, all models, treatment plans and signed consent. What you don't include is any information about the complaint or any references or comments made by third parties. If you get a complaint, act quickly, be respectful. You might be as angry as hell that you got it, right? But the person has made a complaint for a reason. Yes, we will all come across serial litigation people, pains in the backside, but most of the time a complaint has come around because there's a breakdown in communication. So sit on your tongue, bite your tongue off if you have to, be respectful, listen and understand. This clearly matters to the patient or they wouldn't be complaining. Tell your defense organization straight away, try and resolve it, because it's much better to resolve it than stick your head in a bucket of sand and be defensive and run it out, because you do not want, even when you turn out to be innocent, you do not want the 24 months of sleepless nights, hassle, grief, stress, anxiety that a GDC or a civil case will take you through. I've got lots of cases where people have been through the sausage factory at the GDC, come out the other end, vindicated or not vindicated, but never vindicated. They just say, well, nothing seriously found. And they've lost weight, and maybe I should do it, but they've lost weight, their hair's gone grey, they've had a terrible 2 years. It isn't worth it. Refund or remediate if there's any failings. Don't impossibly argue. Don't argue the impossible based on emotion. Don't get cross and don't refuse to see the patient. And if you can, use mediation if they won't do it. So early intervention, say sorry, have empathy, say we will sort it. Do not involve money. Don't say I'll fix it, but you've got to pay me another 50 quid. Just fix it. Because the investment in remedial is much more cost effective in emotional energy and even financial cost than just sticking your head in the sand. And then learn from it, change what you do. Keep away from the lawyers and the GDC. I can't tell you, having been 150 years in dentistry and helped loads of dentists, it's not worth the grief. It's not worth a moment of your life spent in front of lawyers and the GDC, even when you're right. So that was super fast. I'm sure some of you will disagree with some of the things I have, but that's absolutely cool because we're all allowed to make our own decisions. But thank you very much for that somewhat speedy presentation. Thank you.
Great stuff. Well, thank you, Julian. Covered a lot of ground, and congratulations for doing it to time, which is brilliant. So yeah, even as a layman, I learned something there. There's a few questions. The first one actually is just some general, you could say, nodding in agreement about some of the comments you were making about amalgams and composites. One of the questions was about nurse inflation, and when you were talking about that, just for clarity about the inflation in the cost of nurses, what can you recall what that was? I think you talked
Yeah,
about
so if you talk to NASDA, the National Association of Dental Accountants, and you couple that with the fact lots of nurses have not re-registered, in some areas particularly, there's a massive shortage of good quality trained nurses. You know, and so unless you engage really well with your team and your practices, and you know, if you're a poor payer or a just above living wage payer, you're going to get your nurses disappearing off, right? Because someone round the corner will offer another £1 or £2 an hour, and they will move for that, particularly if they're not tied to your practice. So what we're seeing, and I'm seeing it, you know, and I stay in touch with thousands of dentists, you know, all of the groups. I talk to Bupa, my dentist, Roderick's, all of them. And I also talk to loads of independent dentists. I've got 11,000 dentists on my network. And, you know, this is a common theme of I can't get nurses and I can't. And so my advice to all of them is don't try and get new nurses. Work hard to keep your nurses. And if that means you have to pay a bit more, work out how you're going to pay a bit more. Because if you simply carry on with high volume, low profit work, you'll get creeping erosion of your own personal profit margin. And there are some places, I can give you an example of one practice in Sunderland. I can't give you the name under GDPR. One practice in Sunderland whose wage costs, there are 4 dentists in there, there are 6 nurses. His nurse and reception costs, since coming out in the back end of March, on a run rate, is 71% up on nurse costs this year.
Right.
I don't know if anyone on the call is from Sunderland, but apparently there's a serious shortage of, you know, trained nurses.
Yeah, that's really telling.
So that's what I'm told.
The other thing you mentioned there was NLP and some of the training that you put in there. So it might be something we can come back on, but a couple of people asked whether you've got any recommendations for particular courses that you've used or providers that you've used for that.
Yeah, I can. And so what they do, if they email you, because I'll do it now, but if they email you, we can give you some recommendations on people that do good stuff. You know,
okay.
NLP is simply understanding how to relate to people. It's reframing. It's taking something. It's if they fold your arms, you fold your arms. If they cross the legs, you cross the legs. You ask them about them, not about you. You don't tell them, you engage. It's when you get to understand it, it's a very simple technique of engaging.
Well, the research, I mean, it's interesting. The research coming out of the US for surgeons actually is one of the biggest determinants of whether a claim will be made against a surgeon is their tone of voice, just how they go about speaking to patients. So yeah, clearly there's a lot to be learned on that. And then I think this is the final question we've got in was, and I think you may have answered, but just sort of looking ahead, if you were starting out now, you've had your degree of success, but if you were to be starting out now and you were looking at one particular area, what would you be focusing on?
100%. Restore, don't repair. 100%. Because
right.
What I've learned, Kevin, is I started like everybody else. So I did house jobs, then I worked in a high volume NHS practice, then I worked in a mixed practice, etc. And I went down because I trained in Birmingham University, good university, and I was taught to do fillings. And it was only, so I always say I've never had an original thought. So I sat down with a guy called Max Pipe, who was one of my bosses. He's sadly not with us anymore. And he said, well, you know, I was probably 5 years old. He said, why did you do fillings? And I said, well, that's what you do. And he went, why? And we were in the pub at the time, so anyone that knows me knows that that's highly probable. And he said, but would you have a large MOD, BP? I went, well, no, obviously not. He said, why don't you ask your patients what they want? And if they want it, that's fine. This is all about valid consent, informed consent. Don't do things to your patients. Give your patients the options. And I gave you an example. I said, if 3 in 15 patients chose, you'd earn 350 grand. In my experience, I'd say 90% plus of my patients, when they understood the benefit, went for restoration or repair.
Right. Okay. And then there's one more, which is just saying, if you, again, talking about you and your own, because you've had quite a journey, you're quite well known in dentistry, but if you had to pick one, what did you think you said? If you had to pick one of the things that accounts for your success, what would that be?
My success was born out of the fortune in meeting a consultant maxillofacial surgeon called Jeff Manning. Jeff Manning was my consultant when I was a house officer in North Staff's Royal Infirmary, and he taught me that it's not about the treatment. You know, and he was a brilliant guy. He actually, this will make you laugh, right? When I was his house officer, he used to go on the ward at Christmas, and it was muggings because I was the lowest of the low, had to go. And he used to dress up as Father Christmas. He had a belly like mine and a white beard, right? And he used to dress up as Father Christmas. He made me wear green tights and an elf outfit. Can you imagine that? And he taught you a degree of humility. And he used to take us around the kids' wards, the terminally ill kids, and give them presents that he bought with his own money. He was the greatest guy I've ever met. And he basically said to me, he said, you don't do things to patients, right? You work with a patient. You take them on a journey. You do the best you can. Now, I didn't quite get it all when I left then. It took me a while to actually have those bits slot in, but that was probably the best advice. Be kind, be nice, be confident, study, do all that stuff. So my implant stuff, you know, I've done all sorts of stuff in implant. I've trained in Germany, I've been to the States, I've done connective tissue grafting, I've done nerve lateralization, I've done all that kind of stuff. You know, technically I'm good at that stuff. You know, I haven't been sued and I did not so full arch and all that kind of stuff. But actually, the most rewarding is when you take someone that looks like a bag of nails and you make them look beautiful.
Right.
And that's the human side of it. And I think if you get that and you restore, you don't repair, and you give people confidence back, yes, they got to pay for it. They have to pay for their house. They have to pay for their car. They have to pay for their holiday. All right, some people have more money than others, but if you don't share with them how fabulous they could be, how much their confidence will go up. I had a lady, I'll give you one last one. I had a lady came to see me many years ago in Bampton. Anyway, she came in, dowdy lank hair, you know, fisherman's jumper, pretty ugly teeth. Husband had gone off with somebody new. She was really depressed. She was about 42. Anyway, we had a long chat. She cried, I think, in the first. Her husband had just left her. She cried. We had a chat. My nurses were brilliant. We did some diagnostic wax-ups. We planned the case. Anyway, I'm not going to bore you with it all. We made her look amazing. Correction, the laboratory that I pay very well, but I stick on my 25%, and she put it, they made her look amazing because we worked together. We co-diagnosed and I worked with the laboratory. She came back just before I closed my surgery, a couple of years back. And I didn't recognize her. She looked absolutely beautiful, makeup, beautiful hair, you know, had a few body parts tweaked, etc. She came in with a really lovely guy, and she came in, she gave me a hug, and she said, you completely and utterly changed my life. And that, I can't tell you, you can't put money on that. I mean, that's just amazing.
Yeah, it's a lovely thing. It's a lovely thing to be able to do.
It's impossible to describe. And I can give you loads of examples, just changing someone's smile, taking them out of pain, doing stuff, but doing it in a restore, not repair way. See, I'm going off on one now. I've got to learn to stop.
Well, you're passionate about it. You're passionate. So, yeah. Look, I'm really grateful. I think that's been really useful. I hope everyone watching has got something out of this. If anyone's got any questions that they'd like to bring up afterwards, please do just email us at densura.com. And for those who are with Densura, thank you for that. And I hope that you're enjoying the service and that you never have to use too much of it. But if you do, we're going to be there for you. And I hope that you'll tune in again for another one of these webinars. But for now, Julian, thank you very, very much.
Well, can I just say one thing, Kevin? If anyone on the webinar, because each one of those is like a 2-day thing, if anyone wants to make any suggestions, if we can help, we'll help. I'm not going to tell you what to do. We'll just share our experiences.
Yeah, that's great. Okay. Thank you very much, everybody. Thanks.